Hello, I'm really thrilled to join my esteemed co-panelists to discuss with you today multidisciplinary approaches to patients with head and neck neoplasms. I'm Carol Bradford. I serve as the Dean of the College of Medicine at The Ohio State University, where I also serve as a professor of otolaryngology, head and neck surgery. I have no disclosures. So as I reflect on treatments for patients who present with a neck mass, who are diagnosed with a form of head and neck malignancy or cancer, I oftentimes reflect on there are basically 4 modalities to treat our patients. Those are surgery, radiation, chemotherapy, and biological therapy. But I think the most important question for us to ask ourselves as we come up with a treatment paradigm is which treatment really offers our patients the best chance for cure with the least treatment-related morbidity. So as we all know, head and neck cancer care is really very complex. All of our patients really need a full range of support services and specialists. And outcomes are improved when patients are treated in high volume centers. And I'll be sharing more data regarding that very shortly. But I do want to reference what I think is a authoritative text on this topic written by our panel moderator, Dr. May St. John. And this is the Otolaryngology Clinics of North America, where this clinics really discuss the multidisciplinary approach to our patients with head and neck cancer. So I wanted to first point out that survival outcomes truly are linked to patient volumes. This slide demonstrates a hazard ratio of 1.0, which is the baseline for patients treated at high volume teaching and research facilities. The hazard ratio is higher. Again, there is more risk of death of disease in patients treated at low volume teaching and research facilities, at community facilities, and at community cancer centers. And this is specifically for patients with late stage or advanced stage laryngeal cancer. What we've also seen in patients with recurrent head and neck cancer who are referred to tertiary care centers is that prior to referral, there is significant non-compliance with National Comprehensive Cancer Network guidelines, treatment guidelines. And the reason for this non-compliance is based upon inadequate surgery in nearly 60% of cases, inadequate adjuvant therapy in just over 10% of cases, inadequate radiation therapy in about 4% of cases, misdiagnosis in 15%, and then patient refusal in about 11% of cases. This slide discusses treatment adherence to multidisciplinary clinic recommendations, as well as NCCN guidelines improves survival. And this study actually looked at improving patient outcomes through multidisciplinary cancer treatment planning conferences. And again, this publication demonstrates statistically significant improvement in outcome for both NCCN guideline compliance and congruence between my multidisciplinary conference recommendations and actual treatment. The point that is being made here is that if we engage in multidisciplinary tumor board or clinic recommendations, and that will actually improve survival and outcomes for our patients. So this is a photograph of a typical multidisciplinary tumor board, head and neck tumor board. I can share with this group that I have had the privilege and honor of participating in robust multidisciplinary head and neck tumor board conferences for the vast majority of my career. And the beauty of these conferences is the diversity of the participants, both multi-specialty, but also multidisciplinary, interdisciplinary participants. And really that is how we form the very, very best treatment recommendations for our patients. This next slide shows the NCCN guidelines from March 2019, but these guidelines have carried through to the present time about who should be the members of that multidisciplinary tumor board for head and neck cancer patients. And it's really a long list of participants of all surgeons, oncologists, nurses, dentists, prosthodontists, rehab specialists, our speech and swallowing therapists, social workers, nutrition specialists, pathology, including potentially on-site cytopathology, both diagnostic and interventional radiology, and a number of adjunctive services as noted. So basically the participants are diverse in tumor boards, and it's actually this diversity of background and perspective that actually offers the best potential treatment for our patients. So what are the multidisciplinary considerations that inform the care? So certainly there are tumor factors, tumor biology, site, stage, patient and family factors. So what is that patient's social circumstance? What is the family support? What is the patient's goal of care? And again, what are the treatment consideration as well as the toxicity of treatment considerations? When I had the privilege of serving as the president of the American Head and Neck Society, I delivered a presidential address entitled "The Care of the Head and Neck Cancer Patient is a Team Sport," and it truly is. So the goals of our treatment approaches are to cure the cancer while preserving function and both quality and quantity of life, to limit treatment toxicity while preserving the patient's dignity and independence. I would add a significant bullet is to align with the patient's, a well-informed patient's goal of care. As a surgeon, we all know that there are a variety of tools in our toolbox to conquer cancer. And we want to certainly use all aspects of our toolbox, but not sign up for one specific modality. And I'll just leave you with the quote, "If you are a hammer, everything looks like a nail." So we want to make sure we're using that diverse array of treatment options and bringing the best possible treatment to bear on that specific patient at that specific time with that specific site and stage. So we as surgeons and physicians must remain objective, and we must always hold ourselves to a high level of evidence to inform our treatment decision. And this is really the level of evidence pyramid that we're all well familiar with. We recognize that not every stage and site of head and neck cancer is informed by the highest level of open randomized clinical trials. And that's certainly true for the orphan tumors and orphan diseases we treat as head and neck cancer surgeons. But it's important to understand the literature, do the appropriate staging, and make sure we're aware of and offering our patients all forms of treatment that are indicated for that patient's site and stage of tumor. This is an older slide of a whole bunch of clinical trials that actually have been conducted for patients with oropharyngeal cancer. Curiously, at this juncture, the HPV negative trial could not actually meet accrual targets and was closed. But we must continue to propel the field forward and the evidence basis forward by enrolling eligible patients in clinical trials that can help us inform the future of their care. So how to be an expert head and neck cancer surgeon? Well, first and foremost, participate in a high-functioning multidisciplinary care team. Secondly, whenever possible, enroll eligible patients in both observational and/or therapeutic clinical trials so that we can continue to propel the field of head and neck cancer forward. And it is extraordinarily important to coordinate care for our patients to make sure that they get the very, very best integrated, multidisciplinary, and interprofessional, compassionate, high quality, and safe care. So we are really at the forefront of personalized therapy, where we can and must deliver the right treatment for the right patient at the right time. Thank you for your attention.